Morning, everyone. Welcome, and thank you for joining us today for our CME. And today we have Dr. Marcus Cooper presenting for us. Dr. Cooper is no stranger to this group. Dr. Cooper is a consultant gastroenterologist. And for those of you that didn't know, he's an alumnus of Kingsway Academy. He was awarded his medical degree from the University of the West Indies, and he completed internal medicine and gastroenterology at Miami-Jackson Memorial Hospital. He's board certified in both internal medicine and gastroenterology, and also has a master's degree in healthcare administration from Florida International University, and is a lifetime member of Delta Epsilon Lambda Academic Honor Society. He is a member of the American Gastroenterological Society Association, the American College of Gastroenterology, the American Society of Gastrointestinal Endoscopy, and a member of the Association of AWIG, West Indian Gastroenterologists. And of course, Dr. Cooper is no stranger to us as our most recent past president of the Medical Association of the Bahamas and taking our medical conference online. So thank you very much for agreeing to speak to us today, Dr. Cooper, and welcome. And please remember, you can post your questions in the chat. Thank you so much for joining us. Welcome, Dr. Cooper.
Thank you and good morning. Can you hear me okay?
Yes.
Okay, I'm going to share my screen. And we can get started. So today I'm going to talk about pains in the butt or perianal pathology. Can everybody hear me? And can you see my screen?
We can hear you and we can see your screen.
Okay, perfect. All right, so today I'm gonna, like I said, I'm gonna talk about perianal pathology. If you attended the Servier University lecture at the Warwick Hotel, now would be a good time for you to sign off because you've heard most of this before. But if you haven't, I'm going to talk about some of the common conditions that I see and that we all probably see related to the perineum, to the perianal area. A lot of you are maybe uncomfortable with dealing with perianal pathology. It's really nothing to be afraid of. So I'm gonna encourage you to all get familiar with the butt when you see your next patient, particularly if they're coming in with perianal complaints. So this particular talk is gonna be a little bit of an interactive discussion, if you will. I plan to show some slides and ask for a spot diagnosis, and then we're gonna talk about the diagnosis, the way that you make the diagnosis, and current treatment protocols. This particular picture that I'm showing here is a patient who I saw about 2 years ago who presented with some perianal discomfort. She didn't even come with pain. She just came with discomfort. And she had been to see a primary care physician, and she told him that she had a small swelling in her rectum and was prescribed Daflon and sent home. And that particular person did not take the time to actually do a rectal examination. And when she came to me, this is what I found. And this happens to be not an anal cancer, but it's just a very large thrombosed hemorrhoid. And so whenever you see a person or a patient who presents to you with some rectal pain or discomfort or swelling, please just take a few seconds to at least examine the rectum. Don't make an assumption about what the pathology is, and then to refer them to the appropriate service. So I would like you all to use the chat. I'm going to show some slides. I would like you to make a spot diagnosis. You can put it in the chat. I'll give you a few seconds to do that after posting the slide. And then, like I said, we'll talk about the clinical picture, how to make a diagnosis, and the treatment algorithms. Okay, so I'll give you a few seconds to look at this slide. This is a 30-something-year-old female who has a long-standing history of constipation, severe pain with bowel movements, and what's most significant about the complaint is that the pain lingers for hours after the bowel movement. Some bleeding, not significant bleeding, usually just when wiping with the toilet paper, she will see spots of blood. What's most concerning about her complaint is the severity and disablement of the pain. So can anybody put in the chat, like I said, just put in the chat what you think the diagnosis is. Just a few seconds, and if not, we'll just move on. Oh, look at that. Okay, so the overwhelming majority of people are saying that this is an anal fissure. And it is. So it's very unlikely that you will ever see an anal fissure as clear as this. So you can see a tear in the anoderm, just at the entrance of the anal canal. And you can see that the fibers of the internal anal sphincter have been exposed. Now, usually this is such a painful condition that the patient will not actually allow you to do a rectal examination. They won't even allow you to spread the gluteal folds to make a diagnosis. And the diagnosis is very often made just by the character of the pain and the clinical picture. So this is an anal fissure. Anal fissures can occur anywhere along the anal canal, from the anal verge to the dentate line. And the dentate line is formed by the anal papilla just on the inside of the anal canal. Most common patients that present with anal fissures have altered bowel habits. And I say altered because usually it's constipation, but not all the time. Patients may have diarrhea. They may give you a history of straining during bowel movements. Again, the pain is sharp, it's severe in most cases, and it lingers long after the bowel movement. There's often a history of hard stools. If you're familiar with the Bristol stool chart, these would be type 1 or type 2 stools that cause this tear during passage through the anal canal. Of course, you want to do a digital rectal examination if you can, but most times it's not necessary because it's so painful to the patient. And even more so is anoscopy. All that's really required is to just insert the tip of your finger into the anal canal and to press posteriorly if the patient is in the left lateral decubitus position. And if you're able to reproduce the character of the pain just by inserting the tip of the finger and pressing posteriorly, even if you don't see a tear, this is most likely going to be an anal fissure. Now, if you do not feel pain in the posterior midline and the fissure appears to be either on the lateral edges of the anal canal or even anteriorly, you should be thinking about some other pathology as opposed to just a traumatic anal fissure. So there are lots of conditions that can cause anal fissures other than local trauma. So you should have a high index of suspicion for things like Crohn's disease, inflammatory bowel disease in general, syphilis, tuberculosis, even leukemia, some cancers can present with fissures that are not in the anterior or posterior midline. 95% of fissures will be in the posterior midline and will not need further evaluation. So the recommendations usually for the patient, an acute anal fissure, which is usually less than 4 weeks, depending on which source you use, or 8 weeks in other jurisdictions, will only require an increase in the amount of fiber, increase in the amount of liquids, and stool softeners. Now, I put some highlights here on supplemental fiber because not all fiber is created equal. It's not enough for patients who have anal fissures, particularly chronic anal fissures, to just tell them to increase the fiber in their diet. These patients will need supplemental fiber. And so supplemental fiber is going to be things like Metamucil, Phycilium, or Benefiber, Fiber One, some sort of supplemental fiber that's going to retain the liquid and the moisture in the stool and make it softer and easier to pass. That's going to be most important. And then there are other treatment methods for patients who have chronic anal fissures, ultimately ending in surgery. So this is the treatment algorithm for anal fissures. Usually, I will recommend that patients continue the treatment for a minimum of 3 months. Many of them will start to have resolution of symptoms within just a few days after the appropriate therapy. But because of the very poor blood flow to the anal canal, particularly in the presence of an anal fissure, because of that intense spasm of the internal sphincter, these patients will need to be treated for at least 3 months for complete healing of the fissure. So we start with topical application of either nitrates or calcium channel blockers. This is considered first-line therapy. The problem with nitrates and calcium channel blockers is the side effects. And many of these patients, as you can see, and this meta-analysis of clinical trials for topical therapy will show you that patients tend to get headaches quite often. And sometimes patients are able to take Tylenol or Panadol or something like that for the headaches, but many of them will find the headache so severe that they're not able to tolerate the therapy. If they can, we do treat them with topical nitrates. This is not readily available in the pharmaceutical preparation and will have to be compounded in order to get the concentrations that we want. The next step in the treatment of an anal fissure, if topical therapy is not effective, is Botox. So some of you may not be aware that we use Botox quite often in the management of anal fissures that do not respond to first-line therapy. Botox will come in a bottle of 100 units and anywhere from 20 to 100 units injected into the area of the dentate line if you do it endoscopically, or you can put the patient in the left lateral decubitus position and inject it into the internal anal sphincter or into the intersphincteric space. And the Botox will relax the muscle. The pathophysiology of anal fissures is thought to be one of local ischemia because of spasm of the internal anal sphincter. And so the injection of Botox will relax this muscle, allow the muscle to come out of spasm, and then improve perfusion to the anal fissure to promote healing. Of course, if patients do not respond to Botox, and many of them, I would say probably 75% of my patients who I see with anal fissures will respond to either topical application of nitrates or calcium channel blockers or Botox. But if not, then a referral to a surgeon is appropriate. What you don't see here and what we think is going to be the future of first-line medical therapy for anal fissures is the application of topical CBD. So CBD is the non-psychoactive component of cannabis, of marijuana. I know many of you would not admit it, but are only familiar with cannabis being smoked or in brownies, but we now have cannabis in a topical preparation that you can apply to the fissure. And we know that cannabis does have physiological properties, and one of them is vasodilation. The important thing about the vasodilation here with the use of cannabis is that it does not produce a headache like the other topical therapies. And we described a case series here at our local population of the application of topical CBD to anal fissures. This is the very first time that CBD has been used for the management of anal fissures. And we presented this, myself and Dr. Nicholas De La Rota, one of the SHOs in the Department of Medicine. We presented this at the American College of Gastroenterology in 2020 and showed that 100% of the patients, it was a small case series, but we've since expanded it, responded to the application of topical CBD, and most importantly, without side effects. And this seems to be generating some buzz. Dr. De La Rota did an excellent job of presenting this poster. He received the Presidential Award and also the Outstanding presentation award. And we do believe, now that we've been able to expand on this case series, that the application of topical CBD will soon be first-line therapy for the management of chronic anal fissures. Okay, so we're going to move on. That was a bit of a glitch there. So this is a 32-year-old patient who presents with perianal discomfort, swelling around the anus, and occasional bleeding during bowel movements. So just inspection of the perianal area shows this picture. What's the diagnosis? Of course. So this is an acute hemorrhoidal crisis. Okay. So hemorrhoids, very common in our population, typically because of our diets that are very low in fiber. Many of our patients have constipation, chronic constipation, and difficult bowel movements with lots of straining and increasing the pelvic pressure. Hemorrhoids can be painless, or they can be very painful with bleeding. Protrusion of the anorectal mucosa and internal hemorrhoids that are grade 3 or grade 4 are very, very common. What's important to remember is that there are stages to hemorrhoidal disease. So there are mild, patients may present with very mild symptoms in stage or grade 1, where they have some minor discomfort and itching. But in grades 2 through 4, there will usually be some prolapse of the perianal mucosa that is either spontaneously reducible or require manual reduction or cannot be reduced at all in stage 4. Conservative therapy, medical therapy works well for grades 1 and 2, but once you get to grades 3 and 4, they usually require some additional therapy. So here's the treatment algorithm for hemorrhoids. Of course, most important is lifestyle and dietary changes. Like I said before, the typical Bahamian diet is very, very low in fiber. It's usually just meat and starches, is rice and macaroni and all these other things that we eat on a daily basis. So just by adding fiber to the diet is very important. When patients have severe constipation, dietary fiber is usually not enough, and I will always put these patients on supplemental fiber. For grade 2 or 3 hemorrhoids, these patients will usually benefit from rubber band ligation. Previously, and still in some extent, we were using endoscopic band ligation. Now I'm actually putting bands on in the office, and patients do very, very well. Usually requires several sessions for complete resolution of the hemorrhoids, but it does work. Grade 4 hemorrhoids are almost always will require surgical management for complete resolution. Okay, so we're going to move on. So this is a 10-year-old patient that I saw, I've been seeing now for a few years, presented with purulent drainage from the perianal area, induration, swelling, lots of pain. I'll wait for you to give me a spot diagnosis. So most people are saying that this is a perianal or an anal fistula, and that is correct. So you can see here that on the left lateral gluteal fold, there is a swelling, almost looks like a polyp of sorts. There's purulent drainage, and you can actually see in the posterior midline there a small tract, which is the opening of this anal fistula. So very often, anal fistulas or perianal fistulas are associated with inflammatory bowel disease. And this is the most important issue that we must realize when we see patients with fistulas, because there's sometimes is a tendency to surgically open the fistula before ruling out inflammatory bowel disease. If this is somebody with Crohn's disease and you subject him to surgery without excluding inflammatory bowel disease, very often that incision will never heal. And so if you see a patient, particularly a young patient who has signs and symptoms with perianal sepsis, leakage and soiling, pain with bowel movements, and you suspect that it is a perianal fistula, you should send them for evaluation for inflammatory bowel disease, because these patients will need adjuvant therapy in addition to perianal therapy. Sometimes we also, in the cases where it's not associated with inflammatory bowel disease, these patients may be obese, they may have a history of constipation. There are patients with hidradenitis that will have perianal disease as well, who may present with fistulas. So almost always, particularly in young patients, I'll recommend that these patients have a colonoscopy to rule out inflammatory bowel disease. We now have endoscopic ultrasound available, although we don't have the appropriate probe. But endoscopic ultrasound allows us to look through the anal mucosa into the perianal tissues to see if there are fistulous tracts leading into the perianal space. So in addition to just antibiotics, I mean, these patients usually require additional therapy. So the management of a perianal fistula should always include the exclusion of inflammatory bowel disease first. If patients are found to have IBD, particularly if they have Crohn's disease, they will need additional therapy. And what we're using now is anti-TNFs in the form of Remicade or Humira. These work really well. Patients sometimes may also need cetons. Cetons are just the insertion of wires, so to speak, into that fistulous tract. And as you give these persons anti-TNF therapy, the cetons will be pushed to the surface and you'll have healing of the fistula from the inside out. In cases where an inflammatory bowel disease is not associated with the fistula, these patients may need a fistulotomy or fistulectomy, fibrin glue and plugs, or advancement flaps. So the management will primarily be surgical when it is not associated with inflammatory bowel disease. Okay, this is the next picture. Take a few seconds, tell me what you think this is. Okay, so most of you are correct. This is just an anal skin tag. You'd have to get pretty close to this to be able to see that this is really nothing. But this is a 48 or 49-year-old female who presented with what she said was just this unsightly, I guess for her and her partner, an unsightly excess amount of skin at the perianal area, no significant tenderness appreciated. She did not complain of any bleeding, no significant swelling with bowel movement. So this is just an anal skin tag. And this is also very common in our population. Patients will be concerned, I guess. They think it's a hemorrhoid. Sometimes in patients that have severe constipation, you will get swelling of an anal skin tag, but with the appropriate use of fiber, either dietary fiber or supplemental fiber, these things will usually resolve spontaneously. So all that's needed is reassurance to the patient. This is I guess, a more severe vanilla version of a perianal skin tag. Again, if you are not sure about the diagnosis based on the history and examination, you can do a digital rectal examination. The inside of the rectum will feel normal. And only reassurance is required for the patient. So like I said before, rarely associated with pain, usually asymptomatic. If you're not sure about the diagnosis, you can do a digital rectal examination. It should be painless, relatively painless. Anoscopy, I don't find to be particularly useful, but if you're not too sure, you can refer this patient to GI or to surgery for anoscopy or proctoscopy. Okay, take a look at this picture. So this would have been 20-something-year-old male with perianal discomfort, raised papular sort of lesions, some itching, some burning. Not particularly associated with constipation or any change in bowel habits. So this is HPV, and this is perianal condyloma acuminata. So this is not something that we don't see infrequently, relatively common, particularly in our patients that are immunocompromised and are retroviral positive. May be very, very extensive, and the more extensive it becomes, the more painful it becomes. Very common in patients who practice anal receptive intercourse, heterosexual patients with a very high body count, men who have sex with men, all have an increased risk of developing these perianal warts or condyloma acuminata, which is very often not exclusively associated with human papillomavirus. So patients will often complain of pain, itching, bleeding, the feeling of a mass in the rectum, particularly when having bowel movements. If you see this, I mean, usually the diagnosis is relatively easy. Digital rectal examination is not necessary, nor is anoscopy, but an HPV test is warranted. Now, usually this is somebody who would be sent to either the STI clinic. Very often these patients will end up in my clinic for recommendations, particularly when it's not extensive, when it doesn't appear to be surgical, for management of this. The treatment algorithm for perianal warts can be topical and patient administered with the use of topical therapies like podophyllin, imiquimod, etc., and then provider administrated therapy. So very often when these patients start to have extension of these lesions into the perianal space, they will require either excision with curettage or laser therapy, plus or minus cryotherapy. In my experience, I find that these are very, very resistant to treatment, even with the addition of systemic therapy for their underlying condition, and patients will require repetitive therapies to get these things under control. And in some cases will require significant surgical resection. Okay, this is a 7-year-old patient. History of constipation. This mass in the anus that the mother saw after a bout of constipation, freaked out, rushed him to the emergency room. Okay, so all of you are correct except 2, but this is definitely rectal prolapse. And this is a surgical emergency. Usually occurs in younger patients, particularly children with a history of constipation, but may occur in adults as well. I can't say that I've ever seen a patient with rectal prolapse But if I did, I would be sending them to a surgeon. Okay, so this is a 52-year-old patient who presents with rectal pain, particularly with defecation, drainage, purulent drainage, foul smelling feces, and some weight loss. Okay, so most of you are correct. This is a anal tumor, and most likely, given the location of this particular tumor, this is going to be a squamous cell carcinoma of the anal canal. We're seeing more and more of these. These are for some reason, patients are presenting at very late stages. I do believe that sometimes these are mistaken in the early stages for hemorrhoids. Patients are treated with topical or conservative therapy until there's progression, significant pain, bleeding, and weight loss. So this is why it's so very important to do a digital rectal examination particularly when the diagnosis is clear for an anal fissure, but any perianal pathology. Because usually if you do a digital rectal examination, you'll be able to find that there is a swelling that extends into the anal canal, usually to the lateral side. It's very, very firm. Initially may not be painful, but if there's progression and a history that this has been there for some time, this is very likely to be a cancer of the anal canal. Once it becomes more advanced and more extensive, these patients will no longer be amenable just to surgery. Very often they will require chemotherapy and radiation prior to any surgical excision. Again, the common symptoms are rectal pain, constant bleeding, even without having a bowel movement, and a sensation of a mass. So these persons will be referred to either surgery or oncology. And very many times we discuss these patients at tumor board. Now that we have endoscopic ultrasound available at Princess Margaret Hospital, once we get the appropriate probe, we'll be able to determine the extent of these anal cancers and give pretty good staging with endoscopic ultrasound as well. Okay, and I'm going to end with what I consider to be the most important, not necessarily perianal, but may present with perianal symptoms, and that is colon cancer. So without having to ask you to tell me what the diagnosis is, because this is something that you would see during a colonoscopy, but I did want to highlight the way that these patients, the way that these patients presented. The person on the right, a 30-year-old female who presented with painless bleeding. So very often when we have young people that present with bleeding, the assumption is that these people have hemorrhoids. And I always like to stress the point that rectal bleeding is never normal and should never be assumed to be from hemorrhoids. So this person had rectal bleeding, was treated as if she had hemorrhoids. It persisted. She was persistent because of the amount of bleeding. No significant change in bowel habits was detected. And so usually in these patients, when they have persistent rectal bleeding and a digital rectal examination is not conclusive for hemorrhoids, should have at least, at the very minimum, a sigmoidoscopy. Sigmoidoscopies can be performed without any anesthesia, but it does require some endoscopic evaluation. And on inserting the colonoscope into the rectum, you can see multiple polyps just at the proximal rectum into the sigmoid colon. And this patient actually has familial adenomatous polyposis. Unfortunately, even though she was 30 years old, biopsy showed that one of these polyps were indeed cancerous, or was reported as adenocarcinoma, and she required a subtotal colectomy. So whenever you have a patient who presents with rectal bleeding and does not have a clear and definitive diagnosis, irrespective of their age, they should have some endoscopic evaluation. I think it's important to be clear of where the source of bleeding is. If it is only a hemorrhoid, then that's fine, but it's important to make sure that something more sinister is not lurking. The other patient on the right-hand side, this is a 50-year-old male I saw about 2 months ago, who presented with abdominal pain, went to the emergency room, had a CAT scan, and said diverticulitis. And that was it. Was sent home with fiber, antibiotics, but then noticed that he did have some changes in his bowel habits, became kind of sensitized to the problem during March, which is when we have all these colon cancer awareness ads, and decided to come in. And because he was at the age of 50, and because the recommendations, the international recommendations recommend colonoscopy for the first episode of diverticulitis, I took this gentleman for a colonoscopy. And even though he had a CT scan with rectal contrast in the emergency room, he had almost a totally obstructing lesion in the sigmoid colon. And so you can see how colon cancer has these variety of presentations that are sometimes not typical. And it's very important for patients who have any sort of rectal bleeding, or who have a first episode of diverticulitis, or any symptoms that are not clearly defined and can be attributed to some known pathology, particularly after the age of 40 or 45, these patients should have a colonoscopy. Colonoscopy, again, is the gold standard for colon cancer prevention, but is not the only one. The signs and symptoms of early colon cancer are absolutely none. And that's why it's important for persons who meet that target age of 45 now in our population to have some form of colon cancer screening and not wait until there are symptoms. Colon cancer screening with a colonoscopy is a colon cancer prevention test, as opposed to colon cancer detection tests, which are less expensive, but are considered options by international societies. And those other forms of colon cancer screening would be your fecal occult blood test. The first generation test, which is available to us here, has numerous limitations. Patients should be placed on dietary restrictions. There are multiple cases in which you can have false positive or false negative results, which is why we're going to be switching over to the fecal immunochemical test, the FIT test, which is a lot more accurate for human hemoglobin. The fecal occult blood tests, the ones that we're currently using, can give you a false positive if you've eaten red meat, and that's why it's necessary to have dietary restrictions. If you're on certain foods that have peroxidase, can give you a false positive test. So the FIT test excludes all of these, the requirements for dietary restrictions, and it's sensitive for human hemoglobin coming from the lower digestive tract. So that's going to be, hopefully through NHI, will be the standard for colon cancer screening asymptomatic individuals. Fecal DNA, which is not, as far as I'm aware, available in our jurisdiction, is also an option. The virtual colonoscopy is still also an option, and I usually will use the virtual colonoscopy for patients who may have contraindications to having an optical or regular colonoscopy, patients with heart failure, patients with respiratory issues, patients who are on anticoagulation and it's difficult to stop it. If your index of suspicion for a mass lesion or something is relatively low, then a virtual colonoscopy is still a reasonable option. So some of the red flags of colon cancer: unexplained weight loss. These are things that you should be trying to elicit in your history. Unexplained rectal bleeding, particularly in an older person, but I would amend this slide to say in anybody who has unexplained rectal bleeding, they should have some endoscopic evaluation, either a sigmoidoscopy or a colonoscopy. Unexplained iron deficiency anemia. Rectal abdominal pain, unexplained abdominal pain, there's a typo, sorry. Changes in bowel habits are also important. So if you go from having a bowel movement every day to once every 3 days, or if you were previously once every 3 days and now you're going 3 times a day. And a person who's over the age of 45, this could be significant. I'm sure you're all familiar with the term spurious diarrhea, which is when there's overflow diarrhea from a patient who has an obstructing mass in the distal colon. So this is why even persons who are having multiple stools in the day, they previously used to have bowel movements 2 or 3 times a week, can be an indication that there's something going on in the colon. And also those who have a family history of colon cancer, particularly if you have a first-degree relative diagnosed before the age of 60, or 2 second-degree relatives, these people should be having colonoscopies actually before the age of 45. So just some take-home messages, make sure, as usual, with any sort of medical pathology, history is very important, and the physical examination always. Don't be afraid of the rectum. The rectum is your friend. Get used to doing digital rectal examinations. Sometimes it's inconvenient. Sometimes it's uncomfortable, but when persons present with perianal pathology or perianal symptoms, it's important to at least do a visual inspection of the perianal area and sometimes a digital rectal examination. Not all rectal masses or bleeds are hemorrhoids. It's irresponsible to tell somebody that it's probably a hemorrhoid unless you've taken a look to exclude other things. It's important to get control of the symptoms early and not let these things linger, particularly when there's something more sinister going on. And for any doubts, you should refer these patients to GI so that we can do a thorough examination, possibly an endoscopic examination, to determine what the problem is. Okay, so that's 40 minutes. Thank you for your participation and attention, and I will take any questions if there are any.
Thank you very much, Dr. Cooper, for that very practical presentation of what can often be an uncomfortable topic, not only for the patient, but for the caregiver. And so we have a question from Dr. Bassett. Can you use supplemental fiber like Benefiber in children?
Yes, absolutely. So Metamucil, if you're familiar with it, is sometimes distasteful. If you put it in a glass and you let it sit for 10 minutes, it turns to mud and people just don't like the taste of it. So you can use Benefiber in younger patients. It dissolves clean. It doesn't have much of a taste. It doesn't have that grit like Metamucil does. So definitely, I put younger pediatric patients on supplemental fiber when they have severe constipation. We've also I've been seeing some patients that have a Hirschsprung-like presentation where they have overflow incontinence, where the parents are saying that they get constipated and they've been fecally impacted. Supplemental fiber is very, very helpful in this population. It helps to absorb the fluid and to form a bolus that's easier to pass. So yes, the answer is absolutely yes. We can use fiber in the pediatric population.
Thank you very much. An excellent presentation from Dr. Shakira Carroll. She wants to know, can you speak to the availability of the FIT test in our public and private sectors?
Yes, I can. So right now, the FIT test is not readily available. NHIA will be offering the FIT test exclusively for colon cancer screening, and it'll be offered every 2 years. And it'll be the automated FIT test. So it's no longer recommended that population-based screening uses the point of care FIT testing, where like right now when we're using the fecal occult blood test, the provider will develop the card to see if it's a positive test. For population-based screening, it's recommended that you use an automated test that's sent to the lab. It eliminates that the subjective interpretation by different providers, storage, etc. So we will be the NHI, through the NHI providers, we will be offering the FIT test. Right now, I don't think it's readily available.
Okay. An awesome presentation from Richardson Dismangles. Is there a difference in the incidence of colon cancer amongst Blacks versus Caucasians?
That's a good question. I would say what the international literature is saying is that persons of African descent are presenting at later stages with more advanced disease. And this is why the recommendations from the gastroenterology societies in the United States and in Canada as well are recommending, previously the guidelines recommended that colon cancer screening started at 50. And now they've been amended to start screening in persons of African descent at 45. And it's because of this reason, and there are multiple reasons, right? People of color tend to access the healthcare system more often. There seems to be a disparity in healthcare with minority groups. And for some reason, they're presenting at later stages. So I'm not necessarily sure if the incidence is lower, but we're definitely seeing a difference in the way that they're presenting.
Okay, thank you. I'm going to read two questions for you because I think they're related and you may have explained it in your presentation already. How I think it's CBD, not CCB, helping fissure. And good morning. With reference to anal fissures and the use of CBD oils, where can we direct our patients to obtain this product?
So CBD is, like I did say in the presentation, is a vasodilator. And so there are multiple studies, preclinical studies that have shown, that have substantiated the vasodilatory properties of CBD. It was just by happenstance that I actually decided to try CBD in an anal fissure after doing some work on the marijuana position paper for the MAB and finding it to be useful. And it was actually a physician who kind of brought it to my attention that she had tried some CBD oil by drinking it and found that it worked. And then we tried it topically and it worked even greater. And so we started using it and found that there was a trend to improvement. As far as I'm aware, I am the only person that has a permit for topical CBD here locally in country. Topical preparations are available in the US. CBD is not locally available without the permission of the minister responsible for dangerous drugs. But I do have a permit for CBD, and really for the purposes of expanding this case series so that we can report it. So if you do have a patient who has an anal fissure, please send them over, and they will get access to the CBD topical.
Okay, thank you. And Dr. Benjamin Pete asks, rectal prolapse can be a complication of worm infestation in a child. Do you recommend surgical referral or simply treating the underlying problem?
I absolutely would recommend surgical referral. So treating the underlying problem, if you want to give them worm medicine, is fine. I don't think that should be the end all of your therapy. I think these patients, because rectal prolapse seems to happen on a recurring basis, these patients may need surgical correction to prevent further episodes. So I do think you should work in collaboration with the surgeon, if it's a pediatric patient, a pediatric surgeon, to get control of the problem.
Okay. I am not certain who Galaxy A30 is, but edifying meeting. What is the difference in colon cancer occurrence in vegetarians versus omnivores?
Eek. If you're looking for an educated answer, I probably would have to refer you. However, in my experience, and this is anecdotal, colon cancer is not only related to lifestyle. So we know that there is a familial and a genetic component to colon cancer. So I can't say that I have diagnosed any strict vegans with colon cancer, but I can tell you that I have diagnosed people who had very healthy, high fiber diets, who've never had alcohol, who have never smoked, who exercise regularly, and have either advanced polyps or have been diagnosed with colon cancer. So people are sometimes under the impression that if they have healthy diets, that they are excluded from the risk of getting colon cancer, and that is not the case. And screening is recommended in everyone.
Okay, thank you. And maybe you may want to comment on this. I'm not too certain who posted the comment. My apologies. Good morning. If Regu was asking about CCB or calcium channel blockers, we do use them topically. The literature states that it's effective as NTG. What has your experience been, Coops? NTG versus CCB?
Right, so NTG is nitroglycerin, CCB is calcium channel blockers. Nitroglycerin tends to be, and I think it was on that slide, but tends to be a little more effective, but has more side effects. And the side effects are often intolerable, particularly because you have to use these things for them to be most effective. You should be using them 3 times a day for a minimum of 3 months. So because of the severe headaches that sometimes are associated with nitroglycerin topical, calcium channel blockers, because they're also vasodilators, have been recommended. There are some studies out there that show that they are relatively equal in their efficacy. Calcium channel blockers tend to have less of a side effect, but there still are some patients still do have headaches. And so that's why we think that CBD, not CCB, but CBD is going to be a very attractive alternative because the incidence of side effects is 0. But right now, I think that the majority of people who use topical vasodilators preferentially use calcium channel blockers because the incidence of headaches is less.
Okay, thank you. Excellent question. How does the virtual colonoscopy compare with the actual colonoscopy at detection in your experience? And this is from Dr. McPhee.
So the virtual colonoscopy, of course, the worst thing about any of those procedures is the day before. It's the prep. So the prep is the same. The disadvantages of a virtual colonoscopy is that if you identify a lesion, unless you have the ability to provide this person with a same-day colonoscopy, which is sometimes difficult in our setting, this person is going to have to re-prep to have a regular optical colonoscopy to get at the lesion. Also, we know from the literature that virtual colonoscopies are not very sensitive to detect lesions that are less than 5 millimeters. These are unlikely to be any advanced adenomas or advanced polyps at that size, but the recommendation the recommendation for surveillance with virtual colonoscopies is every 5 years as opposed to every 7 to 10 because of this inability to detect smaller polyps.
Okay, thank you very much, Dr. Cooper. I do not see any more questions in the chat. Do you have any final closing comments for us?
No, so I'd like to encourage everybody to, when you have patients who are presenting with perianal pathology or perianal complaints, to make sure that you do a visual inspection of the perianal area. If there is bleeding, a digital rectal examination is recommended. If it's an anal fissure, it may be very uncomfortable, so be sensitive to the patient and always stay woke about colon cancer and colon cancer screening because it's out.
My apologies, Dr. Cooper. I don't know if you could hear me, but your screen seems to have frozen on us. Okay, so thank you very much, everyone, for joining. We did have one final question on the data on incidence of colon cancer in our population. So I will get that question to Dr. Cooper, and we will get the answer back to you. Dr. Cooper is joining us from Freeport, so I'm not too sure if he's having issues with his internet. So thank you very much, everyone, for joining us. Our next CME will be at the end of the month on the 30th of April on the Friday. Our schedule has not changed, second Wednesday and last Friday. The CME at the end of the month is going to be an internal meeting dealing with pensions and gratuities. For those of you that are interested in that one. Dr. Cooper is calling me on the phone. Dr. Cooper, we realize we lost you. Thank you very much.
Okay, no more questions, yeah?
There was only one last question. Do we have any data on the incidence of colon cancer in our population, and how accessible is genetic testing in colon cancer here?
Yes, so I have data going back as far as 2013. I really need to be in the process of turning over that data to the cancer registry now that we have one. I can say from, I think 2018 was the last time that we actually compiled the data. We had about 130 cases that were identified, and every year it seems to be going up. So I do plan to compile this data. We've got together as a group and decided that we're going to document and track the amount of colon cancers that we see every year, and so this data will be available. Genetic testing would be through oncology. It's not free. There is a fee for it, as far as I'm aware. But the oncologists would be the ones who would administer that test.
Okay, great. Well, thank you very much, Dr. Cooper, and thank you for joining us today.
Thank you.
Okay, and thank you, everyone. And remember, if you would like to look at the presentation again, it is available on the UE website, and there is a YouTube link to the presentation so that you could review it in your own time. The feedback link has just been posted in the chat again, and the enrollment key is relief. This meeting is worth 1.0 CME Bahamas Medical Council credits. Take care. Thank you, everyone. Have a good day, and see you in 2 weeks.